Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about CTG or cardiotocography. So, what we want to discuss today, the methods of fetal heart rate monitoring, the definitions, how to use CTG, how to read it, define the risk factors, contractions, baseline rate of the fetal heart, variability, accelerations, decelerations, and lastly the overall impression and what is said according to systematic review Cochrane Library about CTG. Okay, let's start. First, we want to start with the methods of fetal heart rate monitoring. All over the world, the methods of fetal heart rate monitoring is present in this table. Started first by the Bernard or fetal stethoscope, as you see in the picture, one wooden one and metal one. This is the original one and the first method to be used to detect the fetal heart rate by applying the Bernard on the abdomen on one side and this side, and the other side on the ear of the obstetrician. Okay? Then you calculate the fetal heart rate. Second is handheld Doppler ultrasound. It is called Sonicate, as you see in the picture. You apply the probe after applying a gel on the abdomen or on the tip of the probe. Then apply it on the abdomen and the proper position over the chest wall of the fetus. Then you will find the fetal heart rate on the monitor here. So, Bernard and Sonicate. Then, with more advancement, there is external cardiotocography for continuous or intermittent monitoring, as you see in this picture. And this is about our lecture today, with two transducers connected to monitor, one for the uterine contraction and the other for fetal heart rate pattern. This is called external cardiotocography, CTG. Another one is called internal cardiotocography or internal CTG. We apply electrode on the scalp of the head here after rupture of membrane, and this electrode connected to the monitor to detect the fetal heart rate pattern. So these are the methods for fetal heart rate monitoring, and we will choose today the external CTG to be discussed today. Let us start. So what is the cardiotocography or CTG? As you see in the picture, is a technical method used during pregnancy to monitor fetal heart rate and uterine contractions. For what? To monitor the fetal well-being and allow early detection of fetal distress. And the abnormal CTG indicate the need for further investigation and the potential intervention. As you see in the picture, two transducers, one for uterine contraction and the other for fetal heart rate, connected to monitor, and the signals will be written on strip of paper here. So you apply the transducer of contraction on the fundus, detect the tension of the abdomen, which reflects the intrauterine pressure, so can detect uterine contraction, and give signals which be written on this strip of paper. the other electrode on the fetal chest, on the abdomen of the mother, directed toward the fetal chest to detect the fetal heart, which also will be written as a signal on the strip of paper here. This is the two electrodes. This is for uterine contraction, and this is for fetal heart rate pattern. Then the result will be assessed by the obstetric medical team. This is how the paper looked after signals, after we measured the uterine contractions and the fetal heart rate pattern. So I wanted to describe this paper. This vertical line represents the fetal heart rate beat by minute. Okay? This horizontal one representing the time in minute. Each large square considered 1 minute. Each large square considered 1 minute. So, this blue signals here represent the uterine contraction. So, during 10 minutes, there is 3 peaks here. So, there is 3 uterine contraction. Okay? So, usually in the paper you will find the signal represent the uterine contraction down, and signal represent the fetal heart rate pattern up here. Okay? So, we understand now that this blue one is about uterine contraction, and we found here 3 peaks of uterine contraction in the first 10 minutes, and so on. You can calculate every 10 minutes how many contractions. Also, you can see the changes in the fetal heart pattern during uterine contraction. Okay? What about the signal represent the fetal heart rate pattern, represented here in red signals? As you see here, we have a baseline for fetal heart rate. Here it is about 130. Okay? And we have also beat-to-beat variability, which is the distance between the one peak and the next peak, or the difference between them. Usually it is, or normally it is, between 5 to 25, okay, beat per minute, between 5 to 25. This is the norm. Above 25 or below 5 is abnormal. Okay? As you will see later on. You will find sudden increase in heart rate. Sudden increase in heart rate is called acceleration. By more than 15 beats per minute and greater than 15 seconds. We said the horizontal is the time. So more than 15 seconds and more than 15 beats per minute. Okay, so here increased from the baseline, which is 130, up to reaching 145. So more than 15 beats per minute. Okay, this is called acceleration. And you may see sudden drop of the fetal heart rate. We call it Profs or deceleration. Okay, deceleration. What is the definition of deceleration? Drop of the fetal heart rate by 15 beats or more for more than 15 seconds. Okay, 15 beats or more. As you see here, there is drop of from the basal to reaching down here more than 15 beats per minute. So we call it deceleration, or have different types of deceleration: early deceleration, late deceleration, variable deceleration. late deceleration, prolonged deceleration, sinus rhythm. Okay, so we have different varieties. So we have baseline, we have beat to beat variability, we have acceleration, we have deceleration. Okay, all these we wanted to do comment on them on details. Let us go. So how to read a CTG? So to interpret CTG, you need structured method of assessing its various characteristics. So first of all, I need to define risk. Who are at risk, or the high risk pregnancy, because it is very important to detect the high risk of pregnancy. Specifically, I need CTG for them, not for routine use. Okay. Contractions, the uterine contractions. The signal of the uterine contraction will be detected, and its relation to fetal heart rate. Then the baseline rate, the baseline fetal heart rate. This one, the baseline fetal heart rate. Then the variability between peak to peak, or peak to peak variability. Then the acceleration. This is called accelerations. Then the deceleration. This is called deceleration. Then at the end, what is the overall impression after you finish all of this? Your overall impression. Is this CTG is normal, reassuring, or non-reassuring, or abnormal? So you should put the patient at the end in one of these three categories. Okay, who at risk, or the high risk pregnancy? Determine if the pregnancy is high or low risk. This is important as it gives more information about situation during CTG reading. For example, if the pregnancy categorized as a high risk, the threshold for intervention may be lower. So, what about the high risk pregnancy? We have maternal factors and obstetric complications. Maternal factors like diabetes with pregnancy, bronchial asthma with pregnancy, hypertension with pregnancy, smoking, drug abuse, and absence of prenatal care. Obstetric complications include premature rupture of membrane, preeclampsia, post-date pregnancy, intrauterine growth restriction, previous cesarean section, congenital fetal malformation, oxytocin induction, post-date gestation, and multiple gestation. Okay? What about contraction? We record the number of contraction present at 10-minute period, like this. 10-minute means 10 big square, because each big square is 1 minute. Okay, we will find the how many contractions per 10 minutes. Okay, what about the baseline rate of fetal heart? The average fetal heart rate of the fetus within a 10-minute period, also during 10-minute period means 10 big square. We said each big square 1 minute. So during this period, for example, what is the average fetal heart rate? I can see here in this picture, it is about 140. As you see, this is 120, this is 140. This is the average here. Okay, during a 10-minute window. What is the normal? The normal fetal heart rate between 110 to 160 beat per minute. So we wanted to assess the average heart rate over the last 10 minutes, ignoring any acceleration or deceleration. So I'll ignore this acceleration, as you see this one, or any deceleration. Okay? So I need the average basal fetal heart or baseline fetal heart during 10-minute window. Okay, what is the causes of fetal tachycardia making the fetal heart rate more than 160 beat per minute? Like fetal hypoxia, chorioamnionitis, fetal maternal anemia, hyperthyroidism, fetal tachyarrhythmia. What about the fetal bradycardia, which drop below 100 beat per minute? The causes may be prolonged cord compression, cord prolapse, as in this picture, epidural and spinal anesthesia, maternal seizures, rapid fetal descent. What about the variability in CTG? Baseline variability refers to the variation of fetal heart rate from one beat to the next. From one beat to the next. This area is called the variability, baseline variability. From one beat, as you see here, it is about 20, so it lies within normal. Why it is within normal? Because normal variability between 5 to 25 beat per minute. Okay, so between 5 to 25, so it is normal. Here the variability is 10, so within normal also. Okay, so this is called baseline variability. It is a good indicator of how healthy a fetus is at that particular moment in time. Okay, assess how much the peaks and the troughs of the heart rate deviate from the baseline rate. Okay, so according to variability, we can categorize our patient: reassuring, non-reassuring, or abnormal. If between 5 to 25 beat per minute, it is reassuring. If less than 5 beat per minute for 30 to 50 minutes, it is non-reassuring. Also, it is non-reassuring if more than 25 beat per minute for 15 to 25 minutes. Okay? What about the abnormal category? Abnormal category also if less than 5 beat per minute but extending more than 50 minutes, or more than 25 beat per minute and extending more than 25 minutes, or if it is sinusoidal rhythm, which is formed of waves without any beat-to-beat variability, just waves, similar waves, as we will see. Okay, what is the causes of reduced variability? Maybe physiological because of fetal sleeping. This should last no longer than 40 minutes. And this is considered the most common cause. Or the cause may be pathological, like fetal acidosis due to hypoxia. And usually you will find deceleration associating it. Or maybe due to fetal tachycardia or drugs like opiates, methyl dopa, or magnesium sulfate or benzodiazepine, or maybe due to congenital heart abnormalities or prematurity. As you see, variability is reduced at earlier gestation less than 28 weeks gestational age. As you see here, there is reduced variability. Definitely can be seen. Let us talk about acceleration. What does it mean? Abrupt increase in the baseline fetal heart rate of greater than 15 beats per minute for more than 15 seconds. As you see, this horizontal for the time. So more than 15 seconds. Okay? And the greater than 15 beats per minute. The baseline here is 130. Log to this acceleration extend about 150. Okay, so from 130 to 150, so increased about 20. So there is acceleration, because we said acceleration means increase in fetal heart rate by more than 15 beats per minute for duration more than 15 seconds. Okay, so this is called acceleration, this is called acceleration, and this is called acceleration, and so on. The presence of acceleration is reassuring, yes. So it is normal. Acceleration occurring alongside uterine contraction is a sign of healthy fetus. If you found this acceleration, as in this picture, this acceleration with uterine contraction at the same time of uterine contraction, it is a good sign that the baby is healthy. Okay? What about if it is absent, if the CTG has no acceleration, but other items in CTG is normal, so it is of no significance, no abnormality, okay? So long as the other parameters is normal, it's okay. Okay, so its presence only gave me an idea about that the baby is healthy, and it is a good sign, specifically if it happened during uterine contraction. What about deceleration? We said acceleration increase, deceleration decrease or drop of the fetal heart rate more than 15 beats per minute for a duration greater than 15 seconds. Okay, so deceleration is a drop of the fetal heart rate 15 beats per minute, more than 15 beats per minute for duration more than 15 seconds. Okay, we wanted to understand this point. So to understand it, we should know that the fetal heart rate is controlled by autonomic and the somatic nervous system. And in response to hypoxic stress, the fetus reduces its heart rate. Why? To preserve myocardial oxygenation and perfusion. And this reduction in heart rate to reduce myocardial demand is referred to as deceleration. We have different types of deceleration, each with varying significance, like early deceleration, variable deceleration, late deceleration, prolonged one, and sinusoidal pattern. Okay? As you see in the picture, this is an example for early deceleration. This is an example of late deceleration. Okay? This is an example of variable deceleration and prolonged deceleration. In details, what is the early deceleration? The early deceleration starts when uterine contraction begins and recover when uterine contraction stops. Look to the picture. This is the deceleration. Start when uterine contraction begin. This is the uterine contraction here. Look to this lower one, this signal for uterine contraction. Look to the descent here of the fetal heart rate started with the uterine contraction and end with the end of the uterine contraction. Okay, so this is called early deceleration. This is due to increased fetal intracranial pressure causing increased vagal tone. It therefore quickly resolves once the uterine contraction ends and intracranial pressure reduces. This type of deceleration is therefore considered to be physiological and not pathological. So when you see early deceleration, don't be afraid about fetal distress because it is physiological one. Okay? What about variable deceleration? As in this picture, variable deceleration, this arrow looks to the variable deceleration. Okay. Variable deceleration are observed as a rapid fall in the baseline fetal heart rate with a variable recovery phase lasting less than 60 seconds. They are variable in their duration and they may not have any relationship to uterine contraction. As you see here, this one happened without any uterine contraction, so it can happen during any time. Okay? Most often seen during labor and in patients with reduced amniotic fluid volume. As you know, all fetuses experience stress during labor as a result of uterine contractions, reducing fetal perfusion. While fetal stress is to be expected during labor, the challenge is to pick up pathological fetal distress. Okay? So, in every labor, there is a stress of uterine contraction due to uterine contraction. But what is important to pick up the pathological fetal distress? Okay. Variable deceleration are usually caused by umbilical cord compression. So, what is the mechanism for variable deceleration? First, the umbilical vein, look to this picture, this umbilical vein is occluded first, causing acceleration. As you see in the picture, look to this picture, causing acceleration. The obliteration of the umbilical vein causing acceleration of the fetal heart rate as a response to this occlusion. Then the umbilical artery is occluded. So there is rapid deceleration. So umbilical vein occluded, there is acceleration. Umbilical artery occluded, there is rapid deceleration. Then when the pressure on the cord reduced, another acceleration occurred and then baseline rate returned. Another acceleration as here. This is another acceleration. When the pressure on the cord reduced. So there is a pressure on the umbilical cord. First, occlude the umbilical vein will cause reflected as acceleration in the fetal heart rate. Then occlusion of the umbilical artery will be reflected as deceleration. Then relief of the pressure on the cord. Okay, so there is flow, more flow of blood, so acceleration will occur again, making this picture acceleration, deceleration, acceleration, and we call it shoulder, deceleration with shoulder, because we have preceded by acceleration and followed by acceleration. So this deceleration is called with shoulder because preceded by acceleration and followed by acceleration, and we understand now the mechanism. The acceleration before and after variable deceleration are known as shoulder of deceleration. Their presence indicates that the fetus is not yet hypoxic and is adapting to the reduced blood flow. As you see in this picture here, this is acceleration, then deceleration, then another acceleration. So this is deceleration with shoulder, and this is mean that the fetus is not yet hypoxic and can adapt the reduced blood flow during uterine contraction. What about variable deceleration? Variable deceleration can sometimes resolve if the mother changes position. If the mother changes position, maybe due to the pressure of the cord will be released. The presence of persistent variable deceleration indicates the need for close monitoring. So if I saw persistent variable deceleration, I should make it something important and do close monitoring for the patient. Okay, what else is important? If I found variable deceleration without shoulders, this is more worrying, as it suggests that this fetus becoming hypoxic. Okay? What about another type of deceleration called late deceleration? What is late deceleration as in this picture? Late deceleration. Late deceleration began at the peak of uterine contraction. This is a uterine contraction as you see here. Okay? So, this is the peak of uterine contraction. So, this is the starting point of deceleration. We'll start with the peak of uterine contraction and recover after the contraction ends. As you see here, it recovered here. So, after contraction ends here, then deceleration ends here. So, it starts with the peak of uterine contraction and the end after or recover after the end of contraction. So you should differentiate it from early deceleration. Early deceleration start with the start of the uterine contraction and the end by the end. Okay, but here late deceleration start with the peak of the uterine contraction and the end after complete end of the uterine contraction. So recovery of deceleration after the end of uterine contraction. Okay, this type of deceleration indicates that there is insufficient blood flow to the uterus and the placenta. As a result, blood flow to the fetus is significantly reduced, causing fetal hypoxia and acidosis. Okay, reduced uteroplacental blood flow can occur due to preeclampsia, maternal hypotension, or uterine hyperstimulation, or other causes. So, late deceleration is alarming sign. Take care about late deceleration. Okay? Deceleration, if it is prolonged, another type of deceleration. We can say a prolonged deceleration if deceleration lasts more than 3 minutes or the drop of the fetal heartbeat continue for more than 3 minutes. Okay, as you see in the picture. Okay, if it lasts between 2 to 3 minutes, it is classed as non-reassuring. But if it is more than 3 minutes, it is classed as abnormal and it is dangerous. Okay, and it is dangerous and may need an intervention immediately. Okay, so it's called prolonged deceleration. What about the sinusoidal pattern? Sinusoidal pattern is rare, yes, it is rare, but it is dangerous. Okay, it is a very important sign of fetal distress, and its presence associated with high rate of morbidity and mortality. Okay, what the character of sinusoidal pattern? A smooth regular wave-like pattern as this one. Smooth wave-like pattern without beat-to-beat variability. As you see, there is no beat-to-beat variability and no accelerations. Usually stable baseline between 120 to 160 beat per minute. Okay, its frequency around 2 to 5 cycle per minute. 2 to 5 cycle per minute. Okay, we said each large square is considered 1 minute. Sinusoidal pattern indicate one or more of the following: severe fetal hypoxia, severe fetal anemia, fetal or maternal hemorrhage, like vasa previa, fetal hemorrhage, or maternal hemorrhage as abruptio placenta. In normal CTG, if I found normal CTG, but in certain area I found this sinusoidal pattern, only in certain part of CTG, but all other parts of CTG is normal. This could be physiological one. What is the cause? Fetus is some sucking. If the fetus is some sucking, you may see this sinusoidal pattern in a part of the CTG, but you can diagnose it only if the all other parts of CTG is normal, and if you ask the mother to change her position, the sinusoidal pattern will disappear. So it is something physiological due to sucking some by the fetus. Okay? Okay. Otherwise, sinusoidal pattern is dangerous, indicating severe fetal hypoxia or anemia or fetal maternal hemorrhage. So, after we discussed the high-risk cases and the CTG as regard measuring the contractions of the uterus and the fetal heart pattern in the form of basal fetal heart rate, and we said the normal between 110 to 160, and beat-to-beat variability, and acceleration and deceleration with all its types: early deceleration, late deceleration, variable deceleration, prolonged deceleration, and sinusoidal pattern. After all of this, you should put your patient into certain category or describe the CTG as reassuring, suspicious, or abnormal. Reassuring, suspicious, or abnormal. Overall impression is determined by how many of the CTG features were either reassuring, non-reassuring, or abnormal. The NICE guidelines 2017 demonstrate how to decide which category a CTG falls into, as you see in this table. Reassuring if the baseline between fetal heart rate between 110 to 160 beat per minute, and the variability, beat to beat variability between 5 to 25 beats per minute. While deceleration is absent, or if it is present, it is of the early type, okay, with no concerning characteristic for less than 90 minutes. Okay? What about the non-reassuring one? The non-reassuring one or suspicious one, the basal fetal heart rate between 100 to 109 beats per minute, or 161 to 180 beats per minute. What about the baseline variability or beat-to-beat variability? Less than 5 for 30 to 50 minutes, or more than 25 for 15 to 25 minutes. What about deceleration? Yes, variable deceleration with no concerning characteristics, and we will understand what is meant by concerning characteristic later on, for 90 minutes or more. Or variable deceleration with any concerning characteristic in up to 50% of contractions for 30 minutes or more. Or variable deceleration with any concerning characteristic in over 50% of contraction for less than 30 minutes. Or late deceleration in over 50% of contractions for less than 30 minutes with no maternal or fetal clinical risk factor such as vaginal bleeding or significant meconium. This is a non-reassuring or suspicious one. What about the abnormal one? According to the NICE guidelines, the baseline fetal heart rate below 100 beats per minute or above 180 beats per minute. What about the beat-to-beat variability? Less than 5 for more than 50 minutes, or more than 25 for more than 25 minutes. Or maybe sinusoidal pattern. What about deceleration? Variable deceleration with any concerning characteristics in over 50% of contractions for 30 minutes, or less if any maternal or fetal clinical risk factors. Or late deceleration for 30 minutes or less if any maternal or fetal clinical risk factor. Or the presence of acute bradycardia or single prolonged deceleration lasting 3 minutes or more. This is called abnormal CTG. So we wanted to understand the words concerning characteristics of variable deceleration. What does it mean? It means lasting more than 60 seconds, as this one, the deceleration here lasting more than 60 seconds, or reduced baseline variability within the deceleration, as this one, reduced baseline variability within deceleration. Or failure to return to baseline, as this one in this figure. As you see here, deceleration here, but during recovery, failure to reach the baseline. This is the baseline. There is another baseline here. So failure to reach the baseline, to return to the baseline, is one of the important concerning characteristic of variable deceleration. Or biphasic or W shape. Biphasic or W shape like this deceleration. It looks like letter W. Okay? It's called the biphasic or W shape. Or deceleration without shouldering. You remember when we said shouldering is a good sign with deceleration? Absence of shoulder is a bad sign or indicating fetal compromise or distress, as this one. You remember when we said there is acceleration, then deceleration, then acceleration, making two shoulder, one before deceleration and one after. Here there is no acceleration, so no shouldering, only deceleration without shouldering is one of the important concerning characteristics of variable deceleration, making it abnormal, okay, according to the NICE guidelines. Look to this CTG, you can see here the basal fetal heart rate, you can see deceleration behind contractions. This is a contraction, deceleration here start and the end after contraction, okay. So it is called late deceleration, okay. And I told you before, in late deceleration, it starts with the peak of the uterine contraction and end after the end of the contraction, okay. As you see in this figure, there is acceleration here, there is acceleration here, and there is deceleration here. So this deceleration associated with shoulder, okay, and we know what is the mechanism of it, as in this one, okay, this is the shoulder, the acceleration, as I told you before. This sign is W-shaped deceleration. As I told you about it, it is one of the concerning characteristics, the biphasic or double or letter W shape, okay. What is the possible advantage and disadvantage? The possible advantage, more measurable parameters related to fetal heart rate pattern, try to detecting any abnormalities. The CTG traces gives a continuous recording of the fetal heart rate and uterine activity during labor. The possible disadvantage, the complexity of the fetal heart rate pattern makes standardization difficult, with some misagreement between doctors, different doctors, okay. Enter observer variation. CTG prevent mobility and restrict the use of different position or immersion in water used to improve comfort. So if the patient wants to move, I cannot leave her because the electrodes or the transducer is fixed on her abdomen, so she should lie or sit in her place. So there is limitation in the movement of the pregnant lady. If I wanted to do immersion in water to improve comfort, I cannot do that because of electrodes and transducer fixed to the abdomen. So there is limitation in the mobility of the patient. This is one of the disadvantages. One of the disadvantages is that shifting staff focus and the resources away from the mother may encourage a belief that all perinatal mortality and the neurological injury can be prevented. According to NICE 2020, what you are going to do if you have a pathological cardiotocography, first obtain a review by an obstetrician, senior one. Exclude acute events like cord prolapse, suspected placental abruption, suspected uterine rupture, and of course you should deal with this emergency immediately. Correct Any underlying causes such as hypotension or uterine hyperstimulation. Start one or more conservative measures. Talk to the woman and her birth companion about what is happening and take her preference into account and let her know the different lines of treatment that should be done. If the cardiotocography trace is still pathological after implementing conservative measures, obtain a further review by an obstetrician, offer digital fetal scalp stimulation by during BV examination. Pressure on the scalp may cause stimulation, okay, and you will find the CTG becomes toward the normal, okay. This is a good sign if you did digital fetal scalp stimulation and give positive effect on CTG. If the cardiotocography still pathological after fetal scalp stimulation, consider fetal blood sampling for BH and for intervention immediately. What about if we have acute bradycardia or single prolonged deceleration? According to NICE guideline 2020, urgent seek obstetric help. This is the first. If there has been an acute event like cord prolapse, like suspected placental abrasion or uterine rupture, expedite the birth immediately. Do laparotomy in case of ruptured uterus and manage and deliver the baby and repair the site of rupture. Correct any underlying causes such as hypotension or uterine hyperstimulation if it is the cause. Start one or more conservative measures. Change the mother position, okay, for example. Make preparation for an urgent birth. Of course, very important. Talk to the woman and her companion about what is happening and take her preferences into account. Expedite the birth if the acute bradycardia bursts for 9 minutes because it is very dangerous. Lastly, according to a Cochrane database and systematic review in 2017, they concluded that CTG during labor is associated with reduced rate of neonatal seizures, but no clear differences in cerebral palsy, infant mortality, or other standard measures of neonatal well-being. Second, conclusion, continuous CTG was associated with an increased cesarean section and the instrumental vaginal birth, and it is said that the rate of cesarean section increased by 63% due to CTG use, and the instrumental vaginal birth increased up to 15% due to CTG use in some researches. Okay, this is the last slide. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.